Again, welcome to the new CBAS Individual Plan of Care training. I'm glad you could all join us. Before we get started, I just wanted to go over a couple housekeeping items. The webinar is being recorded, and we will be posting the webinar on the CDA website in the near future, so you can expect you'll be able to access that. The IPC form and instructions are currently posted on our CBA website, and you'll see the link there. I would suggest that it will be helpful to have a copy of the form with you as we go through the webinar today. So I would suggest that you get have it on. Make sure you have a form in front of you. We will be putting together an FAQ document, frequently asked questions, following the webinar, and that will be posted along with the PowerPoint slides and recording after we get that developed. Just one more thing, we will be taking questions and answers. We're going to hold those questions until the end of the webinar, but feel free to submit questions via the webinar questions box as we go along today. So we'll kind of just be tracking those questions as they come in and addressing those at the end of the presentation. So as said, my name is Jill Sparrow. I'm the branch chief here at the Department of Aging, the CBAS branch. I have two other people who are presenting with me today, Lee Witzke, who is one of our nurse evaluators, and also Lynn Benjamin, who is our health program specialist. So they will be also presenting today. So just to kind of give a summary of what we're going to be covering today, we're going to provide a status report on the IPC and its implementation, where things currently stand. We'll talk a little bit about the new IPC and how it was developed and how we got to this point. We're also going to be just reviewing some of the federal person-centered planning requirements, which really are the driving force behind the development of this new IPC. We'll also, again, be walking through the IPC and going through with you each of the boxes and giving a summary of any changes or updates that have been made. And we'll talk a little bit about operationalizing parts of this new IPC to give you a sense of how to approach it. And again, we'll be taking some questions and answers at the end of the presentation. So implementation status. So the form, IPC form and the instructions are part of the CBAS section of the Medi-Cal Provider Manual. And before they can be officially made available for use, they do need to go through the formal publication process. So they are moving through the publication process. We do not have a publication date yet. That is uncertain at this point. We are aiming for early next year, but the required IPC implementation will not occur any earlier than March 1st of next year, 2019. Also, just it's similar to when we rolled out the participation agreement. Implementation of the new IPC form will be on a rolling basis as each participant's IPC comes up for review and renewal, and new treatment authorization requests are submitted. So it will be on a rolling basis, beginning no earlier than March 1st. So how did we get here? It feels like it's been a very long road, but we are very close to being able to implement this. The why and how the new IPC, and really it is driven by really federal regulations, and we'll talk a little bit about what those federal regulations are in the next couple of slides. But the IPC was driven by these, and also, more importantly, this was driven by a state commitment to person-centered planning principles. So, and the how of this new IPC, this form that we will be reviewing today was the product of a year-and-a-half stakeholder process where groups of individuals, the providers, managed care representatives, community organizations such as the Alzheimer's Association, CADS, Department of Healthcare Services, and other stakeholders all came together to develop and revise the individual plan of care. So in addition to that, we've, since that time, since that stakeholder process, we've also received additional feedback on the form when we've presented at the various CADS trainings, conferences, and also during a final review by Department of Healthcare Services. So lots of review and lots of work have gone into this final product. So I mentioned federal regulations that are driving this effort. And these federal regulations, the Code of Federal Regulations, 42 CFR, they define person-centered planning requirements for persons in home and community-based settings. And these regulations emphasize the goals and wants, needs, and strengths of the individual. These regulations establish strong consumer protections in the person-centered planning process. And you should all be familiar with this. We've been talking a lot about these regulations, the home and community-based settings and person-centered planning regulations for some time. And we've also been providing a lot of outreach about how these regulations are to be implemented now. We've been moving ahead with the new IPC form, but the form is just a means of kind of capturing the person-centered planning process, but the actual process and implementing person-centered planning in your centers are expected to be implementing that currently. Just a reminder too, we have what you'll see on some of these slides, in blue, these are active links that you can access the information by clicking on those links. So just wanted to put that out there. So a little bit more about person-centered planning. Again, many of you are familiar with this, and hopefully you are. The person-centered planning, it's a process. It's led by and directed by the participants to the extent possible. It includes individuals chosen by the participant. And the idea is that it offers informed choices regarding services and supports. The person-centered plan needs to reflect the individual's strengths and their preferences, goals, desired outcomes, and choices, and also to reflect risk factors and measures in place to minimize those. The plan should also be finalized and agreed to with the informed consent of the participant. And of course, there's the review of the plan. The plan should be reviewed and revised upon reassessment and at least every 12 months, or when the participant's circumstances needs change significantly, or at the participant's request. So there's different components of those federal regulations and what they address. So the federal regulations are further outlined in the California Medi-Cal 2020 waiver. And the 2020 waiver, the special terms and conditions, set forth the special terms and conditions that are set forth in the waiver outline the state's commitment to person-centered planning. And so these special terms and conditions are really the primary reason why we now have Box 12 in the new IPC form, and we'll be talking a little bit about that later. Box 12 captures what the participant identifies as their needs, goals, and desired outcomes. But this special terms and condition requires the IPC to identify the enrollee's preferences, choices, and abilities, and strategies to address those preferences, choices, and abilities. And it also requires that centers allow the enrollee to participate fully in any treatment or service planning discussion or meeting, including the opportunity to involve family, friends, and professionals of the enrollee's choosing. These STCs also require that the IPC ensure that the center ensure that the enrollee has informed choices about the treatment and the service decisions, and that the whole process is collaborative, recurring, and involves an ongoing commitment to the enrollee. So if you haven't done so already, your center may need to adjust, plan, train, or develop programs, and establish multidisciplinary team processes to develop the IPC to meet these person-centered planning requirements. And we've seen many centers that have begun that process and implementing it right now. Okay, so with that said, we wanted to take you walk through the CBAS IPC and talk about some of the changes that you can expect to see. So, as we said, the IPC is designed to support person-centered planning. The revision is to bring the IPC up to date with current program requirements. Its goal is also to facilitate information exchange between the CBAS providers and managed care plans for treatment authorization and service coordination. There should be an increased capacity for documenting, tracking, and measuring the beneficiary clinical data, quality indicators, and outcomes. And also the IPC was designed, the new IPC was designed to improve the form's design, functionality, and its ease of use. So this new form has two parts. Part 1 is the participant profile, which is boxes 1 through 11. And part 2 is the care plan, which will be boxes 12 through 17. And we'll go through these. In these slides, we're going to review each box in parts 1 and 2 and address how to gather information needed to complete box 12, which is where the participants and or their representative express what that participant's needs, goals, and desired outcomes are. And then we'll talk a little bit about how the information in box 12 should inform the completion of boxes 13 and 14. So you'll see here, this is on your right is a screenshot of page 1, which includes center and participant information up at the top, box 1 and box 2. So box 1, which is a treatment authorization request and eligibility box. In this box, we now have combined some pieces of information that were found later in the current IPC regarding initial and reauthorization. Some of these are currently in box 20. Also in this box, you'll see that the eligibility criteria is listed here. They have the categories 1 through 5. And these were formerly in boxes 5 through 9 in the current IPC. But for ease of use, we decided to move them up to the front and also move the description. Currently, there's a description of all the 5 medical criteria categories in the current IPC form. We've removed these from this current form, but they can be found. The criteria categories of CBAS eligibility can be found in the CBAS section of the Medi-Cal Provider Manual. Those are still located there. So that did shorten the form somewhat. Also in box 2, of course, are an area for diagnoses and ICD codes. This shouldn't be new to anyone, should be familiar. All right, so box 3 is medications. I'm going to let Lee talk about box 3 for us today.
Thank you, Jill. So box 3, medications, is where you will be listing all medications, over-the-counter medications or supplements that the participants are taking. The list of medications is divided into 2 categories, prescribed and not prescribed. A new box is provided for you to check if the participant is not taking any prescription medications, over-the-counter medications, or supplements. Up in the top left-hand corner, so if the participant is not taking any medication supplements or over-the-counter medications, you would check this box. There are 2 new lines at the bottom of the box 3, and the new line for the center administers prescribed medications, yes or no, or the participant self-administers prescribed medications at the center, yes or no. So the focus is on what happens at the center here. The active prescriptions section will include current prescribed medications. These may include over-the-counter medications or supplements. As long as it is prescribed by the participant's licensed healthcare provider, it will be listed here. As with the prior IPC version, it is not required to list the dosages and the frequencies of the medications in this box. Examples of prescribed over-the-counter medications or supplements may include vitamin D, glucosamine, or melatonin. When the medication has been prescribed, it would be written in the active prescription section of box 3. The over-the-counter medication section would include any over-the-counter medication or supplement that is not prescribed by the participant's healthcare provider, and these would be listed on the right-hand side. So to recap, there are only 2 categories: prescribed on the left and not prescribed on the right. No dosages and no frequencies. 2 new checkboxes are here to allow the centers to identify any participants who are taking prescribed medications at the center. These checkboxes are focusing on medications administered or self-administered at the center. Prescribed medications administered at the center means nursing services is following all applicable laws and regulations and administering the routine medications at the center. Do not include PRN medications administered at the center when checking this box. Monitoring for the need for and administering a prescribed PRN medication may be addressed in box 13 under nursing services on the treatment plan. So if nursing services is administering a routine prescribed medication, mark this box. Self-administers medication at the center means that the participant has met all the criteria to self-administer their prescribed medications as specified in the applicable laws and regulations. The participant has been assessed as independent, does not need supervision or cues or reminders. The healthcare provider has authorized them to self-administer their medications at the center. The record shows which medications they are self-administering. The MDT is in agreement, and the participant is provided training in self-administration. Include only prescribed, routine, self-administered medications at the center. Do not include prescribed PRN medications when checking this box. If the participant is self-administering routine prescribed medication at the center, check this box. When checking either of these boxes, the center should ensure the information is consistent with the participant's characteristic report definitions. In addition, we wanted to emphasize all the tools available on the Aging website and encourage you to review the medication webinar and FAQs and incorporating them into your training practices. Jill, box 4.
All right. So box 4 is fairly self-explanatory here. This is where you would identify the participant's personal medical provider or mental health care provider. In box 5, these are ADLs and IADLs. We did make some slight change to this. We made some revisions throughout the stakeholder process. It was determined we needed to correct needs assistance for ADLs or IADLs. So this definition was slightly off, and we added queuing required under that definition of needs assistance. Everything else remains the same. The Medi-Cal manual, the IPC instructions, actually provide additional information for these definitions, so you'll be able to find additional information there. And when completing this box, you would be considering the functioning level to be where the person is on their lowest functioning day. And the information here, of course, should reflect what is in the health record. So box 6, that is the current assistive and adaptive devices. What was added here was specialized eating equipment and utensils. This is new. And the most part of that box is fairly self-explanatory. Box 7, which is continence information, here we added clarification around the terms occasionally, frequently, and always. We provided some definitions that help define those parameters, and of course those definitions are in the IPC instructions and should be able to provide you some guidance there on how to complete this section. Box 8 contains nutritional information. Go to the next slide. So this is a new box. Some of this information is currently in box 14 under feeding information. What's new here is body mass index. That now must be calculated if the center knows the participant's weight and height. And the instructions contain calculation instructions how to do that. The body mass index will should identify if the participant's underweight, normal weight, overweight, or obese. And you can see on the slide here just a brief screenshot of what that box looks like. Therapeutic diet is, of course, it would check if the participant is to receive a special therapeutic diet. And again, we provided some definitions of therapeutic diet in the instructions, and those do align with the definitions in the PCR. What is new what is also new in for this box is recently was added the checkbox needs dietary counseling and education. And this is so if it is determined that the participant is in need of this, you would check that. This can be care planned by the RN or the RD dietitian, whoever is providing that service. So that takes us to box 9, which is a living arrangement, household composition, and non-CBAS long-term support services. So this is important background for everyone. It tells everyone what's going on in that person's with their living arrangements and other type of support services that they might have. What's new here, you will see, is the household composition. To check if they live alone or with a relative or non-relative, and then specify the relationship of that person, not the name, but the relationship of the participant to the relative to that participant or that person. There are a few additional fields under support services, and again, there are detailed definitions of these in the instructions. So you would just reference the instructions if you have some questions about what that might mean. So box 10, that references other health services if known within the past 10 months. So in this box, you would be checking the appropriate boxes to indicate the other health services that the participant received within the last 6 months and is currently receiving. So this section we moved some boxes around, but it should really be familiar. Mental health outpatient services, this was previously located elsewhere. Also, what we've removed is the requirement for the county mental health referral, which was formerly in box 10. So that is no longer there. And then we're going to move on to box 11, which contains risk factors, and Lynn's going to talk to you a little bit about the box 11 and risk factors.
Thanks, Jill. Federal person-centered planning regulations require that the person-centered service plan reflects risk factors and measures in place to minimize them. Risk factors are conditions or circumstances that may increase a person's risk for an adverse event or a negative outcome, such as an emergency department visit or hospitalization or institutionalization in a skilled nursing facility. Extensive research about risk factors was presented to the IPC stakeholder work group to determine what to include on the IPC. And the research identified basically 2 categories of risk factors. Risk factors that are internal or clinical in nature, such as the medical or the mental health conditions, number and type of medications, functional status, and more. As well as external risk factors that are considered social determinants of health, such as limited social or family supports, unstable housing, food insecurity, caregiver stress, and more. This slide shows you the composite of the 25 risk factors that the stakeholder work group identified. We also provided options for other risk factors that aren't specified here, as well as an option for none. The current IPC identifies 9 risk factors with the option to specify other, and that's in the current IPC box 17. Addressing risk factors through care planning may prevent adverse events and enable participants to live safely and independently in the community. All risk factors are defined in the instructions. Check all risk factors that apply at the time of the IPC completion based on the MDT assessment and information provided by the participant, family caregiver, or authorized representative. Use box 16 to provide details about risk factors if needed, or check none if no risk factors apply. Checked risk factors support the participant's need for CBAS and may need to be addressed in boxes 13 and 14. If a CBAS provider uses screening or assessment tools to identify risk factors, document the name of the tool and results in the health record. For example, the geriatric depression scale, some memory or cognitive screening tools such as the memory impairment screen, and others. So the next slide, Lee is going to discuss, box 12.
So in box 12 is where the center MDT will document the needs, goals, or desired outcomes expressed by the participant or their authorized representative during the assessment process. Okay, so next slide. Each discipline engages the participant in person-centered manner to express the needs, goals, and desired outcomes. The needs and goals, desired outcomes expressed or otherwise indicated by the participant during the assessment process would be included in these boxes. Include the participant's own words using direct quotes, or in cases where the participant is unable to verbalize or communicate, paraphrase or describe as necessary. The need, goal, and desired outcome should reflect the participant's concern or desired change in their ability or behavior, and or other aspects of the participant's experience or interests. The center can ask questions, open-ended questions such as, what do you need, or what would you like the center staff to help you with, or what concerns you most about your health? The center must document at least one participant express need, goal, or desired outcome, and indicate under which discipline assessment the participant expressed their needs, goals, or desired outcomes. Provide additional information about the participant's outcomes, including their strengths and abilities, such as their motivation to remain in the home and the caregiver's willingness to assist them.
All right, so that brings us to box 13, which is the core services. And box 13 specifies the following CBAS core services: professional nursing, personal care services, social services, and therapeutic activities, which includes the physical therapy maintenance program and occupational therapy maintenance program. And it provides a space for centers to provide the specified information. So what you'll see that's new here in this, in box 13, is that we added therapeutic activities, and that's in quotes, as part of the PT-OT maintenance program title. So the PT and OT maintenance program has always been considered a therapeutic activity. The only change is we've just added the term therapeutic activities to the title. So there's been no change in how centers operationalize this service or care plan to it. Centers should continue to care plan it as they have been. So that is one of the changes that are there in that box. So similarly in box 13, for each of the core services, you would indicate which of the participant expressed needs, goals, desired outcomes from box 12 are being addressed. And the need or problem will be identified by the MDT in collaboration with the participant. You'd be putting in one need or problem per box, and then also what the associated treatment or intervention would be related to that. And of course, the frequency and the goals, what you want to see, what outcomes you would expect to see in each of those core services. And so that same process would apply to the box 14, which are additional services. Box 14, additional services, specify the additional services are physical therapy, occupational therapy, speech therapy services, registered dietitian services, behavioral health services, formerly titled mental health services, and what's new here is transportation services. So just briefly to review, behavioral health services, that is not new, it's a change in terminology. Like I said, it was formerly called mental health services. It's a name change only, which closely the purpose of this change was to more closely align with the language in our Medi-Cal 2020 waiver. The addition of the transportation services in the IPC is new. These services are to be care planned on the IPC. The center will need to care plan for transport to and from the center. And we'll provide some more information about this particular service in upcoming slides. So some more explanation to come on that. So again, same as in box 13, for any of the relevant additional services, you would indicate which of the participants' expressed needs, goals, outcomes from box 12 are being addressed, and then MDT would identify the need or problem, indicate the treatment intervention, the frequency, and the goal. Okay. So let's talk about box 15. This box provides a free text space to describe any significant changes in the participant's condition and or care plan since the last IPC. And this is for reauthorization TARs only. So these may be deletions, additions, or modifications made to the IPC. Again, and this box is for reauthorization TARs only. If this is not a reauthorization TAR, you would just write an A in this box. Box 16 provides another free text space to describe or provide any critical history or information not included elsewhere in the IPC that is, and this is key, that is relevant to the authorization of CBAS services, such as medical or psychosocial history information, or if the participant is not enrolled in a plan or is ineligible to enroll in managed care. So you would use this box to, again, indicate any information that might be relevant to the authorization of CBAS services. So that takes us to box 17, and Lynn's going to talk a little bit about that.
Thanks, Jill. So we made some changes to the current signature page, box 17. We added a signature line for the activity coordinator. The registered nurse, social worker, and activity coordinator must sign and date all reauthorization IPCs. The remainder of the MDT must sign and date the IPC if their particular services will be provided to the participant during the authorization period. We also added checkboxes for both the primary personal healthcare provider and the CBAS center physician, but only one physician needs to sign and date the IPC. We did add some information to the program director signed statement that certifies the following. that all assessments have been completed and the participant meets all CBAS eligibility and medical necessity criteria as specified in the IPC, effective on the date indicated in box in box 17. In addition to that statement, the IPC is a result of an MDT person-centered planning process and is documented in the center records. And also that services scheduled on the IPC will be provided, unless otherwise noted in the participant's health record, after approval of the participant's CBAS eligibility in TAR, and after the participant or authorized representative has signed the CBAS participation agreement, no later than the first day of enrollment consenting to services. All assessments must be completed prior to the start of services on the first day of authorized CBAS services. So those are the changes to the current box 17.
Okay, so that takes us to part of the next portion of the presentation. We wanted to provide, when we talked at the beginning of the presentation day, how you might operationalize this new IPC. We wanted to provide some examples of how you might complete boxes 12 through 14. So we have an abbreviated case study, and emphasize abbreviated. And so I'll take you through that and just show you how, an example, again, of how boxes 12 and 14 might be completed.
Thank you, Jill. So as Jill said, we're presenting a simplified, condensed version of how it looks to go from interview and assessment to documentation on the IPC. So we have a case study of a participant who's diagnosed with hypertension, status post-cerebral vascular accident with right hemiparesis, and depression, and they were asked, "What concerns you most about your health?" The participant replied, "I'm not able to get to the bathroom in time or get my pants up since my stroke. My husband has to help me. And I'm supposed to be practicing with my walker, but I just don't feel up to it. I usually just sit in my recliner and watch TV. And I used to enjoy cooking and working on projects around the house. Now it's just easier for us to have carry-out meals." Through reflecting and summarizing conversations, the MDT was able to confirm that the participant would like to work on gaining independence with ambulating, toileting, and adapting to new ways to prepare meals for her family. Nursing services added that monitoring and controlling her blood pressure would lessen the risk of another stroke, and keeping track of her moods would help the nurses know if her antidepressant was working for her. They let her know that they would provide communication with her primary healthcare provider in the case of any of her medications were not doing what they were supposed to do, and she agreed that monitoring the effectiveness of her medications would help her reach her goals and avoid a setback. We did not include this example on previous slide. We did not include the example in the treatment plan. However, this would be the appropriate place to reflect monitoring her medications, specifically the PRN medications, would be addressed on the treatment plan portion for nursing services. For social services, through open-ended questioning, recognizing that the participant was feeling a sense of loss from her lack of independence and not being able to do the things that gave her a sense of purpose, the social worker informed her that the center participants are actively involved in choosing a monthly theme, and that they have a women's group that does the planning for the theme celebration that occurs one time a month. This group is facilitated by a social worker and promotes regaining a sense of community through active discussions and working toward group goals. She agreed that being actively involved in a project would help her feel as if she was doing something positive and help give her a sense of purpose. Therapeutic activities affirmed with the participant that she would be a valuable addition to the cooking group that was in charge of picking out an appropriate menu item consistent with the center's chosen theme to make for the celebration that they have one time a month. The participant expressed that she would bring in some of her favorite cookbooks to share. So this is how the information obtained during the assessment process and the interviews is transferred over to box 12. You can see that there are 3 of the goals identified here. Number 1, I'm not able to get to the bathroom in time, and I want to be able to go to the bathroom without help. This is identified in the nursing services assessment and the occupational therapies assessment. You can see those boxes are checked. The second goal, I sit home all day and I don't practice walking with my walker like I should. I would like to feel better and not be so depressed. And this was identified under social services and physical therapy. The third goal, or express need or desire, cooking for my family was something I enjoyed doing, and I would like to be able to do that again. And this was expressed through activities, assessment and interview, and occupational therapy assessment and interview. So nursing services is reflecting the participants' goals identified in the first goal on box 12, becoming independent with toileting, and the second goal as well, feeling less hopeless and depressed. The need was identified that the participant would be unsafe if they were not cued for safe transfer techniques. That the participant forgets to use the walker 100% of the time and exhibits unsafe transfers on and off the toilet and her chair. She's unsafe to walk independently due to her lack of mobility and risk for falls. The center is going to provide standby assistance and cue for safe techniques and transfers with ambulation, cue for walker use at all times, and provide daily one-on-one ambulation inside and outside as tolerated. And this aligns with her goal to be independent with her ambulation and avoid falls. Please note that nursing services is using the one-on-one ambulation in addition to any physical therapy or physical therapy maintenance that may be provided. Conversation during the one-on-one ambulation is used to get to know the unique qualities of the participant and address any of her changing needs. Not shown is the need, problem, and intervention and goals for depression, medication effectiveness, and side effects. As I mentioned before, the use of PRN medication, for example, and anti-anxiety medication would be care planned here in this box. Under personal care services, see the need and the problem that has been identified is that the participant would be incontinent 100% of the time if not cued and assisted to the toilet. The participant has difficulty with clothing management and requires assistance. And this is reflecting the goal identified as number 1 for the participant to gain independence with toileting. Please note here that the nursing service is collaborating with OT to maintain consistent verbal cues and techniques for clothing management. Social services is addressing the participant's desired goals, number 2 and number 3, to feel less hopeless and depressed and develop a sense of purpose and accomplishment over her loss. So the need or problem identified is that the participant requires social outlet and opportunity to develop a sense of purpose following loss of functional ability due to stroke. She would be isolated at home if she were not attending the program. Interventions are to provide one-on-one with the participant to explore positive ways to manage her loss of mobility 1 time a week, and the Women's Monthly Party Planning Committee group specifically to nurture friendships and develop a sense of purpose. Social workers are also going to be administering the geriatric depression scale. Please note that this women's group is designed for participants who are depressed. The women's group was designed in collaboration with the psychiatric consultant and is led by the social worker. There are a variety of interventions, individual and group, that the centers may utilize to get to the same goals, and this is just one example. Therapeutic activities. The activity coordinator is addressing goal number 3, in which the participant has expressed a desire to cook for her family again. The need identified is that the participant lacks an opportunity to prepare food and cook meals related to changes with her functional abilities. She has limited dexterity and requires increased time to complete meal prep activities. So this center has a cooking group. So the activity coordinator is going to put her in that group and allow the group to choose one dish each month to prepare and cook for the center, or for a special luncheon for the group itself. And meet one time to choose the menu item approved by the RD and develop a shopping list, and one time to prepare food items for serving. The activity coordinator is also working in collaboration with the occupational therapist here. The OT has provided adaptive equipment for this individual to use, and participants do wear gloves and hairnets when handling food. Okay, Jill.
All right, thanks,
Cover
Lee.
the transportation.
Yeah, I wanted to cover transportation. Wanted to provide an example of what a completed box 14 for transportation services may look like for a participant. So, CBAS centers are required to provide or arrange transportation to and from the CBAS beneficiary's place of residence in the CBAS center when needed, and to identify transportation needs, including special transportation. So in box 14, the center shall indicate the participant's transportation needs to and from the residence in the center, if there are any. If the mode of transportation needs to be provided or arranged, document the frequency and the goal. And of course, then you would need to reevaluate these transportation needs during the assessment or reassessment process every 6 months, or more often as needed. So you'll see that the participant may or may not express a need for transportation to be provided. There may not be a corresponding a identified need in box 12, and that's fine. And there may also be the instance where perhaps the family is providing all the transportation for the participant. In that case, that could be noted here in this box, family to provide transportation. So then it would not be a service that the center is providing. The family is actually providing it. But if if the center has identified that they will need to provide transportation, problem could be that the participant requires transportation to and from her home and the CBAS center. The treatment or intervention could be that the center will transport the participant in the center van to and from the participant's home and the CBAS center. And of course, you would indicate the frequency, which would be each day, if that is the case, each day of participants' attendance at the center, which is 3 times a week. And the goal could be that the participants' transportation needs will be met. So for transportation services, of course, documentation of the participants' attendance and documentation of transit times to and from the participant's place of residence and the center will be used to verify the provision of transportation services that are specified here in this box. In terms of operationalizing this is up to each individual center, how you want to operationalize this and care plan for that. The center can determine, what discipline may be responsible for care planning this on the IPC and conducting indicating in the assessment or reassessment these particular needs. Okay. So that really takes us through the entire IPC form, and we just wanted to again bring to just a reminder that the participation agreement is also a companion document to this IPC, and which it's a standardized form, which meets federal person-centered planning requirements for documenting participants' informed consent to attend the CBAS Center. And as hopefully all of you know, that it has been in effect, this new form was required for use by all centers for new and continuing participants effective March 2017. So all of you, I'm sure, have been using this for some time now. And again, this is just kind of a screenshot of the participation agreement, which is signed by the participant or their authorized representative. Yeah, and both of those are posted on our website. Just a few resources we want to provide, and again, the links here are active links that you'll be able to access when we post the PowerPoint. You'll be able to click these links and access these documents or sites. But we have posted various information on our website relevant to completing the IPC and the participation agreement and information related to person-centered planning. We have, again, CBAS Updates newsletter is a good source to find out any updates regarding the IPC. Since we posted the form and the instructions on the website earlier in September, we've received some feedback regarding the form and instructions, and we will be making some minor edits to the instructions to clarify some information in there. So, one last attempt to provide some additional clarification for everyone. And so, but again, I say they're minor. You won't notice a whole lot of difference, but we will be reposting the IPC and the instructions on our website probably within the next several days. So you'll have the most up-to-date form and instructions there. Just a reminder, we just wanted to reiterate that implementation of the new IPC will not be any earlier than March 1st, 2019, and it will occur after the form and instructions have been published in the Medi-Cal Provider Manual. And it will also occur on a rolling basis as each participant's IPC comes up for review and renewal and new TARs are submitted. But prior to that, CDA, we will distribute an all-center letter and a CBAS Updates newsletter informing everyone of the official implementation date for the form. So there will be, of course, advance notification about that. If you do have any questions about the form or any feedback, please feel free to, you can email us at our cbascda@aging.ca.gov. It's our email address, so feel free to provide some feedback that way. Or if you have questions, you can contact us, obviously, at the branch phone number as well. We do have some time for some questions today, and again, just a reminder, if you do have some questions, please type them into the question box on your screen and submit those. Looks like we've got several questions that have come in, and we'll do our best to answer those. If we don't get to all the questions on today's call, we will be looking through all of them and developing frequently asked questions document that we will post and send out for everybody. So again, if we don't get to your question, we will be addressing those in an FAQ. So I'm going to ask Eden, who's in the room with us too, to read out the questions for us, and we'll do our best to answer those.
Yes, we have several questions that came in. The first one is, if the IPC needs to be revised at least every 12 months, can we have TARs for 12 months instead of 6?
That's up to your managed care plan, and so right now I believe the requirement is every 6 months. Yeah.
Federal requirements say, at least every 12, but
Yeah.
CDA and CBAS branch have established.
Yeah, it is every 6 months.
Unless the managed care plan says otherwise.
We have a medications question. If we list all medications, but some are given and some aren't given at the center, how do we indicate that with only one yes or no box?
If any medications are administered at the center would check the box yes. even if not all medications are given at the center.
For ADLs, if we determine it as supervised/assisted PRN, you would want us to put assisted in box number 5.
Can you read that question again, Ian?
Yes.
So I just want to make sure we understand it.
For ADLs, if we determine it as supervised and/or assisted as needed, would you want us to put assisted in box number 5?
That would be on the worst day? Yes?
Again, yeah, you're considering their functioning, their worst functioning day.
So in all of the information that's provided in the IPC is validated by the record.
Box number 9, under transportation, what do you mean? Access services, family provides transportation, etc.
Okay, so under box 9, under support services, yeah, if you checked the transportation box, you would be indicating means any transportation support, whether it's paid or unpaid, that they're receiving. So transportation support to medical appointments, grocery shopping, church, or other community activities. This does not refer to transportation to and from the CBAS center and the participant's place of residence. Hopefully that answers that question.
Okay. Box 11, risk factors, ADL functional limitations, parentheses 3 or more. Is this for supervision and higher? Also, do we have to care plan for all risk factors indicated?
So in the instructions, we talk about, we don't specify the level or the degree of assistance needed, but if there is assessed that they are having functional impairment in their ADL, that 3 or more could be and is considered a risk factor for an adverse event. So we're not getting into the degree of supervision needed or independence as we are in the IPC when you assess in box 5. And the other part to that question?
Do we have to care plan for all risk factors
No.
indicated?
In fact, we said you may decide to care plan based on the degree of the risk factor if you determine that it's significant enough that there is some intervention required. But we're not requiring that all risk factors are care planned for. Only if during your assessments you feel that they do hold a significant enough risk that you would try to address it on the treatment plan.
Okay. Going back to transportation, which discipline care plans for transportation services? Do we need a separate assessment form?
That, in terms of who will care plan for transportation, that is up to the individual center to determine that. We are not, CDA is not going to direct which discipline should. We'll leave that that is going to be at the decision of each individual center. And in terms of a form, again, that is up to the center to determine how they want to operationalize care planning for this service. So if it's to be included on a current assessment form, a discipline's current assessment form, that's an option. If you want to develop a new form, that is an option. It's going to be up to each individual center to determine that.
In box 12, for disciplines, there is only room for 1 or 2, goals, needs, or desired outcome. Will there be additional sheets provided if participant has more than 2 goals?
Actually, probably if what you're looking at, referring to what was on the screenshot earlier, on the actual form itself, there is room for 5 needs goals to be indicated. So there are 5 boxes. But if there is additional space that is needed, there will be additional, well, if you're using like a hard copy, paper copy, we will be posting have additional supplemental forms for that. But right, there are 5 boxes on the current form.
If LCSW does only assessments quarterly and semi-annually, but does not provide any treatment, does it mean that he does not need to sign the IPC?
I guess the question would be if what was being provided during a quarterly, I mean, is it an intervention or is it an assessment or is it both? Making that determination about what is currently being provided, I guess would lead to the determination of whether they would be signing the IPC.
They're providing services,
Yeah.
and they have a treatment plan.
Yeah, if there is a
signed.
treatment plan that they're conducting a reassessment on, as opposed to just checking in, I guess, and checking in with the social workers on how the participant is responding to the interventions the social workers are providing. On a consultant type basis, and documentation would be referencing the outcome of those conversations. That would not be interventions that are provided directly to the participant and would not necessitate a signature on the IPC.
Okay. Do we have to write a care plan on each diagnosis or just a care plan per participant's stated goal?
The care plans will be written as a result of the needs that are identified through each of the MDT assessments. So regardless of necessarily diagnoses, person-centered planning is getting away from writing a treatment plan based on the diagnosis, more towards writing a treatment plan based on how the participant how the diagnosis is affecting the individual participant.
So what if participants are unable to state need or goal due to diagnoses such as intellectual disability, nonverbal, or Alzheimer's dementia? Would interviewing family or caregiver be okay to obtain a goal need for participant?
Yes, certainly. I mean, that's the idea behind is that if the individual is unable to verbally communicate or otherwise communicate or express, you certainly would want to include a family member or another authorized representative to assist in developing that and trying to determine the needs or wants of that particular individual. So, most certainly.
Mm-hmm. Absolutely.
If we can capture an electronic signature for the MDT and PCP, does the IPC still have to be printed and maintained in a paper chart?
No, the IPC can be electronic, just has to be available. Obviously, you have to provide that to, it should be available upon request, whether it's to CDA or managed care plans, whoever it may be, or the participant themselves, but it can be kept in electronic format.
Can a goal or need be obtained through observation of the client? Example, social services observes the participant having issues sharing with peers during a group session. Can a goal be generated by the observation?
I think observation would be an important component to working with a participant to develop their individual goals, preferences, and desires, but most likely validating that with the participant would be needed through an assessment process.
In the example case, the original participant's quotes said one thing, but box 12 had quotations of something else, something with more insight and depth. How did staff get from those first quotes to the different ones in box 12?
Through the assessment process.
And not interpreting what the participant actually said. Okay. Let's see. Administered GDS is part of the reassessment process that is not a treatment or intervention. Why is it listed in treatment intervention box?
Oh, that take us back to. Thanks.
Oh, it's part of the number 3, administering of the GDS. It's part of the reassessment. Why is it listed as an intervention?
You want to go ahead and answer that?
My sense is, Lynn, my sense is if the individual has symptoms of depression and you're trying to evaluate if they have improved on the medication or not, that the administering the GDS Q6 months and as needed may make sense in terms of trying to monitor if you're reaching the goals that their depression will improve and their GDS score will decrease. So I assume that that's why one might have that as a treatment intervention, even though yes, it might be part of an assessment process that is used for all participants. For this particular participant who has signs and symptoms or perhaps a diagnosis of depression, that might be a more formal treatment intervention than just part of an assessment.
In addition, there's the PRN factor. So it's keeping the practitioner, the social workers who are really just looking at a flow sheet, interventions that they may be using and why they would be using it.
We have a couple more back to transportation. One kind of being a generalized comment, in care planning, transportation is problematic. It changes based on availability of providers and participants' residence. For example, they may start out with paratransit from home and then move to a care home. So they work very hard at ensuring daily transportation. But care planning for that may be problematic due to the various modes.
Well, by all means, you want to take credit for all that work you're doing. It sounds as if you're putting in a lot of interventions around transportation, and this is one place to capture that and make sure that that's addressed.
Okay. Yeah, it's very possible you may have on there that there's a combination of center transportation and other outside transportation services that may be used to provide the service for this participant. So you could capture that there. And we understand transportation needs may change, but certainly could capture that here in this box.
So there are several questions about what is care planned under the transportation services. So it's kind of I guess a grouping of these questions is, if they use access, do they care plan for that? If the participant drives themselves to the center, do they care plan for that? Let's see. And then if they walk, do they need a doctor's approval, which is slightly different.
That would be a no.
No. Okay.
Yeah.
If the participant walks to the center, no, they don't need a doctor's approval for that. Nothing has changed regarding that. If the center needs to provide or arrange for transportation for that participant to the center, from the participant's home to the center, the center would need to care plan for it in this box.
If the participant is independent with their transportation from home to the center and back, there wouldn't be a reason to care plan in this box. However, it might be prudent to put that the participant is independent.
Yes.
Participation agreement question. Do they send that with the IPC every 6 months?
No. Not unless requested, but no. Typically, the participation agreement does not accompany the IPC.
Okay. Can they also capture that electronically and store it electronically?
Yes, I mean the record, the participation agreement, yes, could be stored electronically. I mean, it still needs to have the signature of the participant or their authorized representative, but if it is stored electronically, that's fine.
Okay.
Got to keep up with the times.
Can you clarify where PRN meds are to be noted? Does it go in box 3? There was a comment about box 13.
PRN medications would be listed as a prescribed medication in active prescriptions. You would not note if the only medication a participant is self-administering at the center, or if the only medication the center nursing services is administering to the participant is a PRN medication. Neither of those boxes would be checked. PRN medications prescribed by the participant's personal health care provider for a condition that's based on the participant's eligibility for admission to the program may need to be addressed in the treatment plan in box 13, core services, under professional nursing services. So to recap, it would be listed as an active prescription, a medication that the participant has been prescribed, and if needed, be captured in the treatment plan. Nursing services may want to use the intervention that they would be monitoring for the need to administer the PRN medication, and that would be the prudent place to put that.
Okay. Still with medications, box 3, if participant has 25 meds and only one is administered at the center, then which box do we check? How to elaborate if there's only one medication administered by staff versus the remaining RXs at home by a personal caregiver?
If any medications are administered at the center, you would check that box. It's most likely that the centers will not be administering 100% of the participants' prescribed medications.
What diagnosis should be listed? Those on physician's authorization only, or all those noted in their health record?
If there are diagnoses that are not on the HMP, that are in their health records sent from, let's say, the hospital or some treatment facility, then the center would be responsible to reconcile those diagnoses that are not on the primary healthcare physician's list.
Okay. Question regarding the case management. It only states MMSP or CVRC. However, we have clients that have case managers through county behavioral health. Do we need to include that in the IPC?
Yes, you could, and I believe, getting to the,
There's a space for other.
yes, there's a space for other on there. So if there's an additional support services in place, you would check that and you could indicate there what that might be.
Mental health intervention is not identified under core or additional services. Where would we insert a mental health intervention, i.e. the LCSW sessions?
That's behavioral health. I think if you look at under those services under that's in
It's box 14.
box 14. So there was a change to the terminology, and it was a change in terminology only. So instead of being referred as mental health services, that is now referred to as behavioral health services. And again, that was to reflect, better align with the language in the waiver. But you would indicate that, yeah.
So in the waiver, if you're confused about the change in terminology and wondering what the service, how it's described in the waiver, looking at the waiver, and I'll just quickly read the key points of the language in the waiver. Behavioral health services for treatment or stabilization of a diagnosed mental disorder provided by a licensed, certified, or recognized mental health professional within his or her scope of practice. So it is focusing on the mental health, mental disorder of the individual. I mean, behavioral health does encompass literally substance abuse and use services, but that is not the service that's required to be provided by CBAS providers as an additional service. That said, it doesn't mean that if a participant has a substance use need, or a substance use or abuse disorder or need, that shouldn't be addressed by referral.
So there is kind of a combination of questions here. When there are, needs and goals in excess of 5, or diagnoses in excess of 10, or MDT members in excess of 8, how do they indicate that on the IPC if there's not room for signatures or of those notes?
Well, and I guess the assumption would probably be that if you're using like a hard copy or paper copy of the form, and we would have, I guess it was it diagnoses?
Yeah, for both diagnoses or needs and goals and or MDT signatures.
Well, for needs and goals, we would have we will have additional pages available to download that you could use to supplement for boxes like 12, 13, and 14 right now. So you would be able to add additional ones if needed. For the page 17, the signatures of the MDT, again, there are spaces, and there's a few extra spaces there for signature. You could also, and I'm trying to think of times how often you may have additional. If you have if you have more disciplines that are required to sign this, then there are spaces. Probably
there should be. I mean, we tried to accommodate, so there would be. There's 3 spaces left for registered dietitian, speech therapist, and behavioral health, or LCSW. So that
Should be.
I think we've,
that
Okay.
should accommodate all who would be required to sign.
Okay.
I guess that question may be referring to the several nurses, several social workers, perhaps. And just to clarify, only one representative for the center, one nurse, one social worker would be signing?
correct.
Okay.
You're only required to have that one.
Or I suppose you could determine it by who does the assessment, who has written the care plan
Yeah,
for that particular participant.
that would make sense.
To what extent will centers still be expected to care plan to issues of medical necessity that emerge during assessments versus what the participant states in their goal?
I'm not quite understanding that. It's the conflict.
I think it gets back to what the discipline and professional identifies as a medical issue that needs to be care planned for versus what the participant may view as their, and if the participant hasn't raised that as an issue or concern, but the discipline identifies that.
Okay. I know for nursing services, there may be several needs and problems statements written on the treatment plan that the participant hasn't expressed a goal that necessarily directly correlates to it. However, the participant's ability to be at the center, to remain in their home, to meet the goals that they have expressed, really come down to the fact that they maintain a sense of health. In a lot of respects, working with participants on avoiding, hypertensive episodes or avoiding hyperglycemic or hypoglycemic episodes are a direct correlation to their being able to stay at home and being able to come to the center. If those things weren't managed, they're very high risk of institutionalization. Do you want to add to that at all? So they may not have, I guess in conclusion, they may not have directly recognized those things as something that they would express as a goal, but through a conversation of getting to know them and getting to know their unique needs, respecting their individuality, those conversations should happen, that yes, these are some issues that we would be working on here and why.
It's not an either-or situation.
No.
In that the participants' needs, express needs, goals, outcomes guide what is on the treatment plan, but not to the exclusion of what assessments the various disciplines make related to medical necessity and need to address mental health needs.
Mm-hmm.
But it is person-centered and collaborative, as you've said. So, yeah.
And the next several questions kind of ask the opposite of that. What if the participant wants their blood pressure checked daily, however, there's no diagnosis of hypertension?
Are they somatic? Really getting down to having a conversation with the participant and what is driving that sense of attention that they're seeking, or an interaction with staff that they're seeking, or what is driving this behavior that they are asking for. And you can't eliminate something without replacing it with something. So it would be working with the MDT to kind of figuring that one out.
On section 11, external risk factors, what does it mean hospitalizations unplanned within 60 days? Of what date?
Okay, going to the instructions on this. So what makes a distinction between planned and unplanned hospitalization is if it's planned, it may be it is obviously for a legitimate health problem, but if it's unplanned, it's more of an emergency and reflects that there's some condition that may not be managed well that causes an emergency room visit or emergency hospitalization. So that's related to specifically identifying an unplanned. It's not planned, it's not for a managed condition, but unplanned hospitalization or visit to the ED. Within the preceding 60 days of the completion of the TAR is the time frame we're talking about. And again, this is based kind of on research that has been done to look at hospitalization visits and ED visits related to risk. And so they have used in the research a 60-day time frame just for ensuring that the reporting and the data is consistent, because we're using a consistent time frame. And so that's the time frame that we're using for our definition of that particular risk factor.
Is a higher risk for readmission and problems related to something that they have been.
Right, that it may indicate an unmanaged condition, or particularly within a 30-day time frame when Medicare is penalizing hospitals for a readmission for the same condition within a 30-day period. It's identifying that there's still risk to be managed.
Working with severe or profound ID, the needs goals for the participants become very repetitive, almost cookie cutter. Is this acceptable? If not, how do we address the fact that most severe or profound ID have the same needs goals?
What? again, the center, the disciplines would do their best to work with the participant. Obviously, if the participant is not able to participate and express, or is limited in what they can express, then if there is working with the participant's family or authorized representative, but we expect that to do the best you can to elicit what those might be. So obviously, and making it as individualized as possible.
Okay. For box 12, who should initiate putting down the goals? We noticed that there were 2 team members checking the desired outcomes at the same time.
So I guess it depends on the center and how you want to operationalize that, who completes that. I would, and that would be part of the MDT process and establishing how you accomplish that at your center. Again, part of the MDT process. So we'll leave that up to you to decide how box 12 gets completed.
Mm-hmm.
If a participant has multiple medical providers, it is highly likely that there will not be diagnoses listed on the PCP's authorization that are on other physicians' documentation. Can you explain what you mean by reconciling diagnoses?
So reconciling diagnoses refers to when there is a conflict between documented diagnoses, either on the H&P or other documents from other hospitalizations. The center would want to validate whether or not those were still occurring or still something that the participant had as a diagnosis. So the center would through liaison, ask their primary healthcare physician if this is a diagnosis that this participant has still on their health record.
If someone lives in a licensed care facility, such as a board and care, and their medication is managed by the staff, would they still be medication mismanagement on risk factors, even though the BNC administers? They are unable to manage their own medication.
If the board and care or a caregiver is managing the individuals or administering the medication, one would assume there's no risk of medication mismanagement unless the caregiver is having some cognitive impairment or some reason for not being able to administer the medication safely. So that should be taken into consideration, but one would assume that if there is a competent, able person administering the medication, that there wouldn't be medication mismanagement. But again, that's to be determined in the assessment.
Mm-hmm.
Does all center services, oops, I just jumped, hold on. Does all center services need to refer to number 12, at least one part, needs and goals, except transportation?
I'm sorry, I don't know if
It looks like the question is, do all center services need to refer to number 12?
Does each MDT member indicate
reference back to
A need.
a need or a goal?
If the participant expresses a need or goal or desired outcome in box 12, then the appropriate discipline should care plan to that, and then of course indicate that. It's very possible that through the assessment process and interview process with the participant, perhaps, for example, that OT has a goal that perhaps doesn't relate to anything that perhaps the participant didn't express a goal, but the OT through their assessment process determined that there is a need for their intervention, and they would write it, obviously document that in IPC. But again, that would be in collaboration with the participant and making sure that the participant is in agreement with the OT's identified goal and interventions for that participant.
And I think that, we're expecting that each discipline during the assessment process will ask the participant, how is it that, the center can help you, or what is it that concerns you, let's say about your being able to walk or stand from a seated position, so that each discipline would ask some version of questions of the participant. What are your goals? And gear it to what that discipline's focus might be, or would be. But there may not be. We're not expecting that there has to be a goal in box 12 checked by every discipline if one did not arise during that discipline's assessment.
What if the participant cannot come up with any goals for the program?
Well, we've been asked that question before, and I think that when we use the term goal, I think that's probably going to throw off some participants because they may not even know I don't know what you mean by goal. What does that mean? But I think you get to that by talking to them about, well, what would they like to see? What would they like to see the center help them with, or why have they come to the center? What is it?
What's important to them?
What's important to them? So while you may not get a statement of, well, my goal is for this, you may get a statement of, what's important for me is to remain in my home and be as healthy as I possibly can. You may get something like that.
You're looking for the essence of the participants' past history, what things that they enjoyed in the past, things that brought them a sense of purpose in the past, and inferring that into something concrete and validating it with the participant. Does this sound like something that you would like to work on? They might not be able to express it or get their thoughts together to put it in a perfectly stated desired wish, but that's up to the professionals to have that conversation, to get at who is this person and what is it that we have here that we can offer them, and then talking, validating it back to them, and kind of developing a goal or a desired outcome that the participant is a part of developing in the collaborative process.
Okay. If we document that participant is at level of ambulatory independence on worst day, for example, needs assistance, but that is only less than 5 to 10% of the time, are we obligated to use a gait belt warranted by that level of independence at all times? Often the participant lives alone and manages independent despite how they are assessed at the center.
Use of a gait belt is an intervention that is designed by the physical therapist usually, and that is through the assessment process based on the needs that have been identified. So, yes.
If they're assessing them on their worst day, do they care plan for that, even though they may not be on their worst day all the time?
I guess on the initial assessment, you're really not sure what the percentage of time would be that the participant would need assistance. Through the 6 months of documentation and the data collection that you will be documenting the outcome of what's observed on their ambulatory status. At your reassessment, you would be able to make an MDT decision about going forward on the next 6 months of interventions.
So a reminder that there is at the upcoming CATS conference that there's a one-day intensive course on motivational interviewing, and the comment is that may be helpful for those who want to learn how to engage with participants in a person-centered way.
Precisely, yes, exactly. So I encourage everyone to take advantage of that training.
The remaining few questions are, when will the slides be available? When will the webinar be posted? Where can they access the documents?
So the documents can be accessed on our website, and actually I'm gonna take that over.
It's not at the, excuse me, it was not at the conference. It's at the October 9th CADS training.
Okay.
Yeah.
So just to clarify, the motivational interviewing training is on October 9th, and that is special registration at CAD's office, I believe, here in Sacramento. So I believe that's true. And CAD's, please, Lydia or anybody, please give us a shout out if I got that wrong. But
She fixed it.
okay. All right. Real quickly, just want to show you. We can. Okay. So you can find the IPC form and instructions on our website. If you go to aging.ca.gov under our programs providers, go to forms, and then eligibility and service authorization, you will see the form and instructions posted there. As I said, we will be, hopefully, I believe, I'm estimating within the next week, reposting the IPC and the instructions with the minor edits that we made to the form. So you won't see any significant changes to them, but just some minor modifications. But we will indicate, we'll have a new revision date there, so you'll know. In terms of the slides and recording for today's webinar, we will get those posted as soon as possible, and you would be able to find that on our training page on our website, and that would be here. So we will have that up and posted. We do have to, it will take us a little bit of time to get it transcribed and posted, so we thank you ahead of time for your patience on getting that up.
If we have time, there's one final question that came in.
Okay.
The participant with CBA used as an example had goals which addressed improvement versus maintenance alone. Can one aim for improvement in the goals?
Of course.
Yes.
Yes. That's, yeah. Okay. Well, if there's no other questions, Eden?
No, just a kind of an ask for future trainings on documentation and flow sheets and documenting more in progress notes. So.
Okay, yeah, we would love to do that. And I think the question about the training reminds me too, we would be working closely with CADS to provide some additional training on the IPC and additional more clarification on that later this year, hopefully. So stay tuned for that. I know CADS is looking at offering some of that, so we will be partnering with them to provide that for everybody. In addition, just want to thank everybody for participating today, and hopefully, if you will, we'll get this posted as soon as possible. So if some of your staff were not able to attend today, they will be able to listen to it online after we make it available. And we encourage you to have your staff listen to the training and educate themselves as much as possible about the new form. If you do have additional questions after today, please feel free to email those to us. And again, we're going to be taking all those questions and developing a FAQ for that, and we'll be posting that as well. Well, thank you, everybody, and I hope you have a good afternoon, and talk to you soon. Bye-bye. Sure.
I did hear this stuff broadcasting.
Yeah. I'd like a bell to go off when
I need to, looks like it's recorded in this computer, so it's next time.
I don't think
Was it recording on this room? 'Cause I thought we had to click it from.
I know we're clicking from here.
Okay.
I just have to find out where.